So I'm a partner in Owen Mitchell. We specialise in medical negligence. We've got 11 offices, and at any one time in the London office alone, we've probably got 40 or 50 birth injury cases that are being investigated. I think we are very keen to always work with the NHSLA, to work with healthcare professionals. We put on a lot of training days, and we're very keen to share our experience, what we see, because of course when there's any kind of birth injury, then there is a huge human cost, but there's also a huge cost to the Department of Health, to the taxpayer, to society. So at any one time we've probably only got, I would say, 4 or 5 cases where there's any GBS involvement. Most of the birth injury cases, as I'm sure you know, will be cerebral palsy cases. Largely, I would say, as a result of CTGs having problems not spotted, or problems spotted and then somebody not coming when perhaps they should come, and it's largely down in our experience to training, lack of resource, and be really interested to speak to you, Kathy, about what you see as the issues, because there's obviously a huge cost involved. So the statistics. We've been through all these statistics. I'm going to try not to keep repeating what you've heard from other speakers during the course of the day, but we need to provide some context to GBS infections and those cases that give rise to litigation. So these stats just give some context to that. So you can see in broad terms, 700. These are the GBS support group stats. 700,000 babies born annually, 230 born to mothers who carried GBS, 88,000 become colonised, 700 go on to develop GBS infections, and 75 babies die. So obviously with these statistics, the vast majority of the babies, the great majority of survivors of early onset disease do so with no long-term damage at all. But the cases that we tend to see involve the babies that die, or the babies who suffer long-term physical disability. So just to give you the legal context, so to succeed in a claim for compensation, we have to prove that the care that was received was negligent, that's breach of duty, and that but for that negligence, then the outcome would have been different. So when we talk about breach of duty, we're talking about care that falls below an accepted standard. So, in other words, care that no reasonably competent doctor would have provided or failed to provide. And it's not enough to show just that the standard of care fell below an acceptable standard, was negligent. Our clients find this quite hard to understand. We have to show that that's actually what's caused the injury, and sometimes that's quite difficult, because there are often cases where we can show that there has been a breach, but actually the damage has been caused often earlier in pregnancy when we're talking about maternal cases. So the standard of care is what we call balance of probability, so we have to show there's a more than 51% chance that the damage has been caused as a result of that negligence. Any damage has to have been reasonably foreseeable. Now, Philip this morning mentioned the case of Montgomery, which is actually a really important case. I'm not going to spend ages on it, and in fact, Philip gave a very good summary of it this morning. And I don't know to what extent it has made a huge difference, because doctors always did have to explain risks and benefits to patients. And in that case, it's very hard. It's a nervous palsy case that's very, very hard to see how it ever got decided the way it did initially and ended up in the Supreme Court. But it has provided a new case on consent, and people are taking it very seriously. I actually sit on the Clinical Disputes Forum, who are now looking at, with various Royal Colleges, are looking at consent and how this has changed consent. Because the way that the law is going is patients are being given a lot more autonomy. But having said that, there was a case just last week, Philip, Tamsin and Bart's Hospital, where actually the judgment, Judge Jay in that case, seems to have decided that actually doctors do know best. So I don't know how far Montgomery is going to take us, but what Montgomery decided was that there is no standardised advice anymore. So there's an objective test and a subjective test. So the objective test is, what would a reasonable patient expect to be told in relation to risks and benefits in this particular situation to be able to arrive at a decision about it? And then you've got the subjective test of the doctor, and it's what should that doctor, with that particular patient in mind, have advised? What should that particular patient have been told? Now, because Philip raised it earlier, I've been thinking during the course of the day as to just how much impact it might have on Group B strep and screening. And I think, as far as I can go at the moment, it's just to kind of watch this space, because I think although certainly if a problem arose and there had been some risk factors, some red flags, whatever, and a woman hadn't been advised, then I think, yes, you're definitely going to be in trouble. But whether you can extrapolate from Montgomery that all women should now be screened when the risk is actually still very low, I'm not so sure. But we can debate that, and it's certainly an important decision. So breach of duty and GBS claims. So breaches of duty come in various forms, as we've just seen. They can come in forms of consent. So we'll often pursue cases on the basis of failure to consider infection as a possible cause of complications during pregnancy, failure to prescribe and administer antibiotics for early onset neonatal infection, and failure to recognise and treat sick babies in the first hours following birth. So these are the nice guidelines. We've looked at these earlier, the 5 key principles. So in cases where these guidelines haven't been followed, then we allege that this is a breach of duty. But obviously there's a risk, which people have discussed earlier today, between minimising exposure to antibiotics in babies who don't have the infection and administering antibiotics to babies who do have it and who are likely to catch it during birth. So this is where we have to assess and act. Doctors have to assess and act on the risk factors. So again, looking at breach of duty in GBS claims. So I'm not going to go through the nice guidelines again. We went through them this morning, the red flags and the risk factors. So if there's a red flag or 2 or more non-red flag risk factors or clinical indicators indicated, then investigations need to be performed and antibiotic treatment started. So if there are no red flags and only 1 risk factor or clinical indicator, then clinical judgment is to be exercised. So if there's a failure to recognise a risk factor or a failure to follow the correct pathway after a risk factor has been identified, then this is often alleged as a breach of duty. And any delay in administering antibiotics would also be a breach of duty. So once the breach of duty is established, as I say, then the causation argument would go something like this. On a balance of probabilities, 51% or more, had the infection been identified and antibiotics administered, the damage wouldn't have occurred. And statistics show that preventative measures can reduce the rate of early onset GBS by up to 90%, which supports the arguments on balance of probability. So how do the courts assess compensation once we've established breach of duty and causation? So the job of the court is to put the injured party back in the position they would have been, so far as possible. Of course, in reality, it's impossible, but so far as they would have been had it not been for the negligence. And what we claim for depends on whether the baby has survived or not. So I'm going to look at some case studies. So let's look at case study 1. So in this case, the due date was 22nd of March 2009. Attendance 27th 27th of February, pre-labour premature rupture, sent home with a leaflet. Attendance 28th February, changing colour of light, signs of early onset labour, admitted, baby born by Ventouse on the 1st of March. ABCOS scores satisfactory, baby came floppy, pale, no respiratory effort. Condition deteriorated over the next 24 hours and resuscitation was required on 2 occasions. Intensive care was withdrawn at 50 hours of age and the baby died on 3rd of March 2009. The cause of death was early neonatal sepsis. So what we alleged in this case was that there was a failure to prescribe antibiotics, admit for observation, women presenting with spontaneous rupture of membranes until 37 weeks should have been given antibiotics, failure to prescribe and administer antibiotics during labour, failure to follow guidelines for pre-labour rupture of membranes and guidance issued by the RCOG. And we alleged on the balance of probabilities, if antibiotics had been given on the 27th of February 2009 during labour, the baby wouldn't have developed an infection and she wouldn't have died. So liability was admitted in this case. They said that, they accepted that there had been a breach of duty and causation. So what were we able to claim for? PSLA is pain, suffering, loss of amenity. The most you get in this country for pain, suffering and loss of amenity for the most catastrophic, so like your tetraplegic, serious brain injury, is between £250,000 and £300,000. So when you see those huge claims in newspapers, those are almost always because you've got children or adults sometimes, or anyone with a profound disability who needs 24-hour care, often with 2 carers the rest of their lives, or is a very high earner. But for generally what you get for the injury itself is very low. So in this case, if there's a bereavement claim, then the figure now is £13,000. At the time of this case, it was lower than that, but what you get for a bereavement claim is £13,000. If you have a baby who's stillborn, then you don't get anything at all, actually. So unless one of the parents has suffered some sort of psychological harm as a result of being there, then those claims don't have any value. So in this case, there was a psychiatric claim for the parents, bereavement award, funeral costs, probate costs, some travel expenses, some care for the mother, cost of private scans for future pregnancy, some loss of earnings, etc. And so this claim settled for £27,000. Now, it is hard to imagine something more awful happening to you in terms of human cost than having a baby that dies. But actually, the government is about to bring in, I'm going to get a little bit political just for a minute, if you allow me. The government is about to bring in fixed recoverable costs for low-value claims. Low value, they think of claims anything under £100,000. So it's not going to affect the cerebral palsy claims. But this sort of claim, it's almost certain that these parents would not have been able to bring a claim at all. And these are the cases, and neonatal death cases, that are going to be very badly affected by the government proposals. So let's have a quick look at case study 2. So mother became pregnant, first child, May 2006, due date February 2007, 17 weeks gestation, admitted to hospital with abdominal pain, no vaginal loss, some discharge, high vaginal swab taken for infection, prescribed painkillers, sent home. Swab results sent to the labour ward revealed a heavy growth of bacteria GBS. The result was filed, but no treatment was given or further action taken. Membranes ruptured at term +7. No acknowledgement of the GBS infection. No antibiotics were administered during labour. Concerns with regards to the baby's heart rate during labour. Baby born at 21:43, large amount of thick meconium-stained liquor seen with delivery of the fetal head, and the umbilical cord was seen to be lying loosely around the baby's neck. Baby born in poor condition at birth, required extensive resuscitation. Heart rate above 100 BMP was only detected at 20 minutes of age. Chorioamnionitis, scan revealed brain damage, baby's got cerebral palsy. So this baby was born in a very poor condition. So in this case, we allege they failed to swab, they filed a swab test revealing the GBS without taking any further action, failed to recognise it until the swab result until after the baby was delivered, failed to prescribe antibiotics during labour, failed to pay any adequate heed to the national guidelines, amongst lots of other allegations. And we said, had antibiotics been given during labour, the infection would have been avoided and the brain damage would not have occurred. And liability, again, was admitted in this case. We send what's called a letter of claim, which sets out our allegations. They have 4 months to send a letter of response saying whether they admit or deny, and they admitted in this case. So in this case, we claimed, how many minutes have I got?
5.
Oh, good, thanks. So in this case, we claimed care. Both gratuitous care is where parents or other family members provide care, and it's discounted because it's provided by family members, but also commercial care because they had brought carers in. Case management, they had a case manager help them access therapies and help find them carers. Occupational therapy, physiotherapy costs, all sorts of equipment, travel expenses, miscellaneous expenses, interest, etc. And then future losses, future loss of earnings, future care, assistive technology, physiotherapy, education, speech and language, accommodation, court of protection. Because if you have a child who is born with a disability so that they can't manage their own affairs, then the court of protection have to become involved, so that attracts costs as well. But the largest item, as always, will have been case management and paid care. So this case settled for 3.1 million as a lump sum, with periodical payments of 220, 240 and 300. What happens with, well, years ago, I can't remember how many years ago now, probably about 15 years ago, all cases settled by way of a lump sum, and all that happened is that all we ever knew is that the lump sum was going to run out. And then periodical payments were introduced, so a lot of items are capitalised, but care and case management are always now paid for, in these sorts of cases, are always paid for by way of periodical payment, so it doesn't run out, because all the parents ever want to know is that their child is going to be cared for as long as the child lives. That's all that matters to any parent that I've ever acted for. So the care and case management are these figures of 220. So that 220 is up to age 11, 240 will be up to age 18, 19, then 300 for the rest of the child's life. So you can see, once you start to capitalise those amounts, you can see why you get these figures in the newspapers of 8, 9 million. If the child dies early, then that obviously, and quite rightly, that money just stops getting paid out. So this is another case, delay in diagnosing and treating GBS bacterial meningitis in early neonatal period. Claimant's been diagnosed with cerebral palsy, affecting all 4 limbs, epilepsy, severe short-sightedness, severely disabled, requiring assistance with all activities of daily living, waking carer. She has no independent mobility, can't sit or stand unsupported. She's very large, booked in at 38 weeks gestation, admitted on 8th December 2008 for induction. The mother was found to have active genital herpes lesions. Induction was delayed until 12th of December. She was induced on the 12th, membranes ruptured at 1:50 on the 15th. 22:15, the mother started to shake, high temperature, the mother started to vomit, 4 steps delivery on the 16th, APGAR scores 1 at 1, 8 at 5. Mother's temperature 38.9. Mother started antibiotics, baby was grunting, taken to the neonatal ward. The plan was to admit her to SCBU for IV antibiotics, bloods and chest x-ray in view of possible sepsis. Paediatric review, grunting again, paediatric review again, still grunting. The plan was to screen for infection, start antibiotics, but due to handovers and demand of services, there was a delay starting the antibiotics. This baby, again, suffered brain damage and again has cerebral palsy. So there was a delay in screening for infection, administering the antibiotics, and she has sustained brain damage, cerebral palsy. A letter of claim was sent, and liability again was admitted in the letter of response. So this claim is currently still being quantified, but it's, as a capitalised sum, it's going to be somewhere between 8 and 10 million. This is a child with a compromised life expectancy. So I mean, so to round up, so the awards that are being made out in these cases for claimants vary from about, well, £13,000 if you've got a bereavement case. If there's no bereavement, it can be less than that. I mean, I've said to 10 million. I mean, some cases are 10 million, 12 million. I mean, it depends on how long the child eventually lives, what the final value is. But you can see that the figures are huge. In addition, of course, the trust has to pay the claimant's legal costs, which can range from £10,000 to £100,000, depending on how much work has to be done, how long it goes on for, as well as their own costs, the NHSLA costs, the trust costs. And as I said, at any one time, Owen Mitchell London office alone probably has 4 or 5 GBS cases under investigation. There are lots of other offices, lots of other law firms, so there's a lot at stake. And then, of course, there is the cost to society, because many of our clients will end up living on benefits. They will not be able to work ever, and they will be dependent. A lot of clients will be dependent on NHS treatment for the rest of their lives, and certainly any who don't have any compensation claim, but there hasn't been any negligence. So finally, GBS infections have a devastating consequence for many children and for their families. The human cost is enormous, whether it's death, whether it's a lifelong disability. And in many cases, as we've heard from so many speakers today, these infections are preventable, treatable. If litigation ensues, then it's very costly. And the breaches of duty that we see tend to follow a pattern: failure to consider infection as a possible cause of complications during pregnancy, failure to prescribe and administer antibiotics during labour, failure to prescribe and administer antibiotics for early onset neonatal infection, failure to recognise and treat sick babies in the first hours after birth. So, happy to take any questions.